Chianu, a 3-year-old girl, is brought to the pediatric emergency clinic. Her parents report an acute onset of high-grade fever and chills. Physical examination. On the malar area of her face, there is a tender, bright red, subcutaneous swelling. The involved skin feels indurated and exhibits a classic pay-to-orange texture. The lesion displays a distinct, well-defined border. Clinical diagnosis. This presentation is the textbook definition of erysipelas, a deep dermal cellulitis with lymphatic involvement. Laboratory confirmation. A needle aspirate of the subcutaneous fluid is sent to the microbiology lab. Gram staining and culture on enriched media reveal pinpoint beta hemolytic colonies that confirm the diagnosis of Streptococcus pyogenes. Group A Streptococcus. Microscopic appearance. Streptococcus pyogenes appears as gram-positive, spherical cocci measuring approximately 0.5 to 1 micrometer in diameter. Arrangement. The cells are arranged in short chains or pairs. This chain-like morphology occurs because cell division takes place strictly in a single plane, and the daughter cells remain partially attached. Spores. They are completely non-motile and non-sporing. Capsule. Certain highly virulent mucoid strains produce a protective capsule made of hyaluronic acid. Because hyaluronic acid is a normal component of human connective tissue, this capsule is non-antigenic. It acts as a major antiphagocytic shield and binds to host CD44 on epithelial cells to facilitate pharyngeal colonization. Growth requirements. This bacterium is a highly fastidious aerobe and facultative anaerobe. It cannot grow on ordinary basal media, such as nutrient agar or peptone water, and is completely inhibited on MacConkey agar. Inoculation and incubation. Specimens must be incubated onto enriched media containing blood, serum, or carbohydrates. Plates are incubated at 37 degrees Celsius aerobically, typically in the presence of 5 to 10% CO2 to enhance growth. Colony morphology. On sheep blood agar, S. pyogenes produces characteristically small, pinpoint colonies 0.5 to 1 millimeter. These are surrounded by a wide, 2 to 4 millimeter, completely clear zone of beta hemolysis, indicating the complete lysis of red blood cells. Selective media. Crystal violet blood agar is commonly used as a selective medium to isolate S. pyogenes. Pyogenes from throat specimens. As crystal violet inhibits the growth of normal oral microbiota. 7. To differentiate Streptococcus pyogenes from other gram-positive cocci, 3 diagnostic tests are essential. Catalase test. All streptococci are catalase negative, which immediately distinguishes them from catalase-positive staphylococci. Bacitracin sensitivity test. S. pyogenes is highly sensitive to bacitracin. Placing a 0.04 U bacitracin disc on a blood agar plate produces a wide zone of growth inhibition. This serves as a rapid screening marker to separate Group A Streptococci from other beta hemolytic streptococci. CAMP test. S. pyogenes is CAMP test negative. This distinguishes it from Streptococcus agalactiae, Group B Strep, which is bacitracin resistant, and CAMP test positive. Cell wall antigens. M protein. The principal virulence factor of gas. It is a surface protein that inhibits complement-mediated opsonization. Antibodies against M protein are protective. However, there are over 150 M serotypes, classified via Griffith typing, and over 200 M genotypes, explaining why individuals suffer from recurrent infections. Crucially, certain M proteins exhibit molecular mimicry, sharing epitopes with human myocardial proteins, tropomyosin and myosin, and cardiac valves, which drives autoimmune damage. Lipoteichoic acid, LTA, fimbriae, and F factor. These cell wall structures bind to host cell fibronectin, facilitating firm adherence to the pharyngeal mucosa. Hyaluronic acid capsule. Prevents phagocytosis and allows the bacterium to evade immune detection. Secreted toxins. Streptolysin O, an oxygen-labile, strongly antigenic hemolysin. It damages host cell membranes and stimulates the production of anti-streptolysin ASO antibodies. In skin infections, cholesterol lipids in the skin inactivate SLO, meaning ASO titers remain low or absent in skin pyoderma. Streptolysin S, an oxygen-stable, serum-soluble, and non-antigenic hemolysin. Streptococcal pyrogenic exotoxins, SPEA-BC. SPEA and C are bacteriophage-coded superantigens that bind nonspecifically to T-cell receptors and MHC class II molecules, triggering a massive cytokine storm. SPEB is a chromosomally mediated protease. Spreading enzymes. Streptokinase, fibrinolysin, dissolves fibrin clots to facilitate deep tissue invasion. Streptodornase, DNase B, liquefies thick purulent exudate by breaking down host cell DNA. Anti-DNase B antibodies are highly antigenic and serve as the diagnostic marker of choice for skin infections, pyoderma, and post-streptococcal glomerulonephritis, PSGN. Hyaluronidase breaks down hyaluronic acid in connective tissue, allowing the organism to spread rapidly. We divide the clinical manifestations of S. pyogenes into suppurative, pus-forming infections and non-suppurative, autoimmune complications. Suppurative infections. Streptococcal pharyngitis, sore throat. Classic childhood infection presenting with an erythematous pharynx covered in white, purulent follicular exudate. Scarlet fever. Occurs when the pharyngitis strain is lysogenized by a bacteriophage carrying the genes for SPE3. It features a sandpaper-like skin rash, Pastia's lines in skin folds, and a strawberry tongue. Impetigo, pyoderma. Superficial skin infection starting as red papules that transition into vesicles and pustules, eventually rupturing to form honeycomb-like crusts. Cellulitis and erysipelas. Spreading dermal and subcutaneous infections. Necrotizing fasciitis, flesh-eating disease. Severe, life-threatening infection of the deep fascia and subcutaneous tissue. Features include rapid tissue necrosis, dusky skin, and local anesthesia due to cutaneous nerve infarction. Streptococcal toxic shock syndrome, STSS. Rapidly progressing shock, hypotension, multi-organ failure, and active bacteremia. Non-suppurative sequelae. Acute rheumatic fever, ARF. A type 2 hypersensitivity reaction that develops approximately 3 weeks following pharyngeal infection. ARF never occurs after skin infections. Anti-M protein antibodies cross-react with host myocardial tropomyosin, myosin, and valvular tissue via molecular mimicry, causing permanent valvular damage. Post-streptococcal glomerulonephritis, PSGN. A type 3 hypersensitivity reaction that typically occurs 1 to 3 weeks after pharyngitis or 2 to 6 weeks after a skin pyoderma. It is mediated by the deposition of antigen-antibody complexes on the glomerular basement membrane, seen as subepithelial humps. Patients present with edema, hypertension, oliguria, and smoky hematuria. PSGN carries an excellent prognosis with spontaneous resolution. Specimen collection. For pharyngitis, throat swabs are collected by vigorously rubbing the posterior pharynx and tonsillar pillars. Swabs with synthetic tips, Dacron or rayon, are preferred. Direct microscopy. Gram-stained smears of pus or wound exudate reveal gram-positive cocci in chains and abundant neutrophils. Direct microscopy is not used for throat swabs due to the presence of normal oral streptococci. Culture. Inoculated on blood agar, yielding pinpoint colonies surrounded by wide beta hemolytic zones. Rapid Antigen Detection Test, RADT. Bedside immunoassay detecting Group A carbohydrate antigens directly from throat swabs. It has high specificity, greater than 95%, meaning a positive result is diagnostic. However, because its sensitivity is variable, 55 to 90%, a negative result in a symptomatic patient must be confirmed by a throat culture. Serology. ASO titers, elevated greater than 200 IU per milliliter in pharyngitis and ARF. Anti-DNase B antibodies, elevated greater than 300 to 350 U per milliliter. This is the marker of choice for pyoderma and PSGN. Penicillin, this is the undisputed drug of choice. For pharyngitis, oral penicillin V for 10 days or a single intramuscular injection of benzathine penicillin G is recommended. Macrolides, oral erythromycin or azithromycin are prescribed as the primary alternative for patients with a documented penicillin allergy. Necrotizing fasciitis, immediate surgical debridement, most crucial, must be paired with parenteral penicillin G and clindamycin. Clindamycin is essential because as a protein synthesis inhibitor, it shuts down the ribosomal transcription of deadly pyrogenic exotoxins. STSS and severe invasive disease, treated with penicillin G, clindamycin, and intravenous immunoglobulin, IVIG, to neutralize circulating SPE superantigens. Penicillin susceptibility. To this day, outstandingly, zero penicillin resistance has been reported in clinical isolates of S. pyogenes. If a patient fails penicillin therapy, it is due to non-compliance or the presence of co-colonizing beta-lactamase-producing normal flora, such as Moraxella, in the pharynx, which shield the streptococci. Macrolide resistance. Resistance to erythromycin and other macrolides is common and widespread. Question 1. A 5-year-old boy presents with a severe sore throat and a high fever. A throat swab is collected, and culture on sheet blood agar reveals pinpoint beta-hemolytic colonies. Which of the following biochemical profiles is most consistent with the causative pathogen? A. Catalase positive, bacitracin resistant, CAMP test negative. B. Catalase negative, bacitracin sensitive, CAMP test negative. C. Catalase negative, bacitracin resistant, CAMP test positive. D. Catalase positive, optician sensitive, biosoluble. Answer. B. Discussion. Streptococcus pyogenes, Group A Streptococcus, is catalase negative, bacitracin sensitive, and CAMP test negative. Option C describes Streptococcus adolactiae, Group B Streptococcus. Option D describes Streptococcus pneumoniae. Question 2. A 12-year-old girl presents with dark, tea-colored urine, facial puffiness, and mild hypertension. Her history is significant for a superficial skin infection on her legs that resolved with honey-colored crusts 3 weeks ago. Which of the following serological findings is most sensitive and specific for confirming a prior streptococcal etiology in this patient? A. Elevated anti-streptolysin O, ASO titer greater than 200 IU milliliter. Elevated anti-DNase B titer greater than 300 U milliliter. C. Elevated C-reactive protein, CRP. Positive rheumatoid factor, RF. Answer B. The patient is presenting with post-streptococcal glomerulonephritis following a case of impetigo. Because cholesterol and skin lipids inactivate streptolysin O, ASO titers remain low or absent after skin infections. Therefore, anti-DNase B is the diagnostic marker of choice for pyoderma-associated PSGN. Question 3. A patient diagnosed with severe necrotizing fasciitis of the lower extremity is taken immediately to the operating room for surgical debridement. Along with high-dose intravenous penicillin G, the infectious disease consultant recommends adding clindamycin. What is the primary pharmacologic rationale for adding clindamycin to this patient's regimen? A. To overcome the absolute penicillin resistance of Streptococcus pyogenes. B. To target co-infecting gram-negative enteric bacilli. C. To shut down ribosomal synthesis of streptococcal pyrogenic exotoxins. D. To provide synergistic bactericidal cell wall disruption. Answer. C. Discussion. S. pyogenes exhibits zero penicillin resistance. However, in severe toxin-mediated diseases like necrotizing fasciitis or toxic shock, clindamycin is added to the regimen because it is a protein synthesis inhibitor that suppresses the production of pyrogenic exotoxins, mitigating tissue necrosis and cytokine storm.